Palmer. I am a licensed independent clinical social worker, and I'm currently employed at CAMC in Charleston as a faculty social worker. Today, I'm here to talk to you all about social determinants of health, something that I'm sure once we get into, you all will find that you deal with on a daily basis, or have become very familiar in the field of work that we all do. So I just wanted to mention I have no disclosures to report. And yeah, our objectives of what we will learn today are we will define what social determinants of health are. We will review some geographical trends. We will look at this through an intersectional lens. We're going to go over what adverse childhood experiences are and how those show up in our own lives and our patients, especially. And this topic can be pretty heavy because we're talking about every type of issue that people can face coming into healthcare and what we as providers or people in healthcare are expected to do about it. So I like to come from a solutions point of view that helps me prevent burnout and keep it going. All right, so here is an example of a graph that I like when discussing what social determinants of health are. These are the concrete and abstract factors of an environment that a person is born into, lives, works, worships, socializes, and interacts with others in. Of course, the specifics on here, as you can see, are a wide range from economic stability, food security, access to healthcare, what quality of education people are having, what education options they are having, social community and context, and physical safety of people's neighborhoods and environments, whether it be the safety of them, what's going on in their neighborhood, access to clean water, food deserts, etc. So, yeah, so why is it important for us to know about social determinants of health? So based on the type of health concern you are reviewing, we know that social determinants of health account for 25 to 60% of health outcomes in population level studies. And again, this is a wide variance due to the specific type of health we're looking at or health symptom or outcome. When looking at social determinants of health, we talk about upstream versus downstream interventions. So, upstream would be what people are coming in with, what types of experiences they're having outside of the healthcare setting. And then our types of services are the downstream interventions that we provide as healthcare providers. Social determinants of health explore the root causes of mental and physical health and not just the symptoms. This type of approach, as someone who is a clinician and works in a clinical and medical setting, I'm constantly balancing to not pathologize what people are going through, but also understand that, we do work with mental and physical health disorders. But I think when we use a social determinants of health informed approach, that helps us navigate that. All right, and when talking about social determinants and the individual risk and protective factors, risk factors and protective factors, of course, are extremely relevant when identifying a treatment plan. And you'll hear me reference a lot during this talk about treatment plans in order to provide our patients with the most successful plan, depending on what we treat. Of course, these types of factors are the forces of our individual patient's strengths and weaknesses. When looking at someone who has limited access to transportation, reconsidering if they are capable of having in-person or telehealth visits, which is a beauty of telehealth. But also I work with patients who have a variety of mental health disorders, specifically substance use disorder. And we know our patients having access to labs where they can do urine drug screens can be a bit tricky, but definitely something that we try to set them up for success with their treatment plan. I do believe that high quality care includes having this type of informed approach and discussing these types of strengths and barriers to treatment with our patients is incredibly helpful, I would say, from the beginning. This allows patients to know that we see what their barriers to treatment are and that we're willing to work with them. It's not just about flexibility, it's about being realistic with what people are capable of and not capable of doing. Of course, we live in West Virginia. Transportation sucks here, it just does. There have been some resolutions depending on where people live with a variety of connections, but still that's a hot topic is transportation. And that's just one example that I'll give throughout. So social determinants and mental health. Oh, I've lost my note here. Excuse me. There we are. Um, Many of us know I was reading the chat to see where people are coming from. We know that mental health disorders are extremely prevalent in West Virginia. I don't have to review those stats here. Barriers to care include transportation, internet access, health insurance, lack of knowledge of what mental health is. And I like to really emphasize that with people, especially again with substance use disorder, because a lot of the time I get patients who are actually engaging in binge drinking or having some type of substance use, whether it be alcoholism, cannabis use, etc., and they are not identifying that that is they're engaging in a substance use disorder. So I can't tell you how many people I've worked with as well who have experienced depression for decades, anxiety for decades, mood symptoms, etc. And they're actually not even aware of what is going on. This has been so normal for them. And what that tells me is that these people are extremely resilient and capable, and also they are struggling with access to quality information to let them know that they are experiencing a mental health disorder. And then another note here is literacy and education limitations. Something I had to learn very quickly in my practice working with patients is to not assume that everyone can read at the same level of I can or that they can read at all. So whenever providing psychoeducation with patients on these topics, it's important to have a social determinants of health approach, informed approach, and review these types of concepts with them in terms that they understand. Um, Also, we know that the onset and severity are impacted by social determinants of health based on how a patient is when they're diagnosed with something, if they've ever been treated, if it's been treatment resistant before, or if, again, if they've been surviving decades with a mental health disorder and they have not known it, or a physical health disorder. Um, that can make things a bit more difficult to treat depending on where they're going and where they are in their recovery or life. Another difficult, I would say, barrier when managing care in West Virginia is preventive or early intervention measures are not easily accessible or widely practiced. A lot of my patients who happen to experience X, Y, and Z, I get referrals from schools, legal systems, or other types of systems that are not exactly equipped or focus on intervention or more of a treatment-based approach. So again, we're relying on school systems and legal systems, we as in our culture, society, to address really, really big problems that they just don't have in their toolkit to address. Also, I don't know if any of you all ever were a part of the DARE program, the program that was about abstinence or tried to teach abstinence regarding substance use. And that was a preventive attempt to get kids to just say no. I don't believe DARE is still being practiced, but we know that that actually was not effective. So hopefully, as time goes on, we can put more effort in preventive care. And also, there's a mental health providers shortage. And that definitely negatively contributes to access to care. Once a wait list, I don't know if any of you have tried to get some care recently and have been put on a 30, 60, or 90-day wait list. We do see that people are actually less likely to attend their first appointment if they've been waitlisted first. And they've either lost motivation or things have changed for them. They've tried to find care elsewhere. But yes, our provider shortage definitely contributes to lack of care. Okay, so I am a social worker by education and trade, I would say. And this is a huge theory that we practice in social work. It is a person and environment perspective. This, I believe, is a simple simple way of looking at someone's situation and who they are as an individual and building a framework of either their treatment plan or what our patients are navigating outside of our offices in order to better serve them. So our micro level here is our self, and then our meso level here is who people are interacting with outside, such as peers, work, family, culture, church. And then, of course, our macro level, which are legal policies, rights, social policies, institutions, safety, regulations, laws, and government policies. One that I've been hearing a lot about here in our hospital meetings is the Big Beautiful Law will go into effect, or in January of 2027, and we are going to be seeing some Medicaid cuts. So that is something that we are anticipating for some of our patients. So again, this big, beautiful bill, excuse me, uh, going into effect on a government level, how that will affect our individual patients. We will see a trickle down effect of that. And I'll get in a little bit more of the specifics as we continue on. I do have a case vignette today. Changer, tell me if this is an appropriate time for this. I sometimes ask my people in the middle of it.
Yeah,
Feels
whatever
good.
you feel comfortable with. This is fine.
Okay, great. So this is a patient who I saw before who was a 48-year-old Black male who lived in Southern West Virginia. He was presented to individual therapy after a referral was placed for him when he sought care for high blood pressure. And his symptoms included vision changes, headaches, and chest pain. Patient was not sure why the referral was placed other than he was stressed out during the appointment. After getting to know him, it was discovered that this patient has lost his entire immediate family, all due to medical related issues, which did lead to a distrust in providers. And this all occurred in the last 5 years. He does have health insurance, he does have a stable living environment and a vehicle, but he does have financial strain. His PHQ-9 scores, which are how we measure depression, was a 23, which we would consider severe. But he reported that he doesn't feel depressed. And I also thought it noteworthy that he does not adhere to his blood pressure medication. And when normally I talk about this with the people who I normally do this lecture with, I ask, how can we help this patient? So if anyone feels comfortable putting in the chat or unmuting themselves and maybe identifying some target points of care that we can start with, I would appreciate it. So first and foremost, how can we help this patient, or what can we do to get this patient the care? Some care.
I think that, can you hear me?
Yes, I can. Thank you.
I think that we need to determine why he's not been adhering to his blood pressure medications. I know he's got the financial strain, so does that mean that he's having to use that money for bills, for food, instead of him actually getting it for his blood pressure medicine? And then that, of course, can cause more strain on him. So I think maybe we start there first.
Okay, great. Yeah. So asking him why, what's causing you to not want to engage in this treatment?
We did have a few things come in the chat.
Oh,
One
okay, good.
is Sarah kind of piggybacked on what was just said, where it says, what does he need to stay consistent with medication?
Mhm.
We have teach him how to get reimbursed for mileage or offer telehealth. We have first and foremost need to build rapport and then find out what side effects he gets from the blood pressure medications.
Okay. So person-centered. Love all of these. Yes, yes, because the medication is huge here because this patient is experiencing significant side effects of having high blood pressure, where he is making me a little nervous, and I think others as well. Yeah, and building rapport. This patient does not trust providers. He has, a lot of challenges around that. And I would say trauma, but I don't want to speak for it. What social determinants of health or person and environment factors are impacting this patient's of care? Again, some things to consider are people's culture, um, their knowledge or education around what mental or physical health are, access to care. I see something in the chat.
We have social
Social
conditions.
conditions, yeah. Being a Black male in Southern West Virginia, this person was really looking for a Black male provider, and we had we were not able to provide that for this patient.
Potentially what depression is, since he said
Mhm.
he doesn't feel depressed, but his PHQ reflects otherwise. Healthcare literacy,
Yeah,
loss of family, money strain.
yeah, yeah. Lack of support system. Yeah. Yeah, this person probably is navigating a lot of loneliness, and now we're asking him to do a bunch of things that he has not done before. And I don't look like him, and I don't have shared experiences that he does. And being really transparent about that during the process, I believe was helpful for a therapeutic rapport. And last question here. Again, I appreciate your all's feedback. This helps move things along. Why is it important to consider these factors when treating patients?
To meet them where they are was in the chat.
Absolutely. I've thought about adding motivational interviewing into this, but I think it's long enough.
It impacts this life, therefore it impacts treatment.
Absolutely.
Successful treatment, holistic care.
Yes, which we talk about. Okay, so I'm talking to some professionals here. Great. All right, well, thank you all for your contribution. All right. So another concept that I like to look at when talking with people about social determinants of health are Maslow's hierarchy of needs. A lot of the time, I like to ask people where they're coming from, but I know we've got a lot of people on here. So just kind of thinking about where your patients are coming in or when your patients are coming in and what they're asking of you to help them with. Um, Depending if I'm on the inpatient unit, sometimes I've got people coming in because of physiological needs. They don't have access to safe shelter, struggling with breathing, depending on the situation, high risk types of patients, and they're coming in and they're wanting better self-esteem. And oftentimes tell people, we gotta work from the bottom up. Now, sometimes people are coming in a little further along the pyramid, if you will, and let's say they're looking for acceptance of themselves or, with themselves or with others, but they really struggle with this sense of love and belonging. It's really going to help. It's really difficult to manage acceptance when you don't feel like you experience love and belonging with anything bigger than you, community, people, etc. And I, again, find this really helpful to show patients like, you're asking me for this here, but where are we really here? And how can I help you with safety and security? Intimate partner violence, something I deal with almost on a daily basis, really, really tricky. Um, Again, patients come in asking me for things higher up on the pyramid, but really their safety and security. Sometimes even physiological needs are something that can't be met. And anyone who's worked with any patients in intimate partner violence situations know that it's a long and meticulous process to help people navigate that safely. Okay, so here are some health impacts of social determinants of health. I kept it relevant to West Virginia, just, do the topic. Um, a lot of what we hear and already know, the highest on adult obesity rates, an average of 40% of adults are obese. Chronic diseases that dominate morbidity, such as heart disease, cancer, chronic lower respiratory disease, diabetes, stroke, kidney disease, and Alzheimer's. We know that chronic diseases reduce quality of life, which increase healthcare needs and often lead to disabilities. Therefore, they place really, really heavy burdens on individuals, their ones who care for them, and healthcare and social support systems. I don't know about y'all, but sometimes I have a patient, more often than not, come in with a very, very high needs list. They're experiencing disabilities, they're struggling getting consistent income, they have all these health complications, and like they don't have a primary care provider. And so I feel like I'm a helper, as many of us are, and so therefore we're starting with just like this holistic type of approach, and it can be very overwhelming. And then, of course, we know that healthy eating choices do correlate with socioeconomic status. I have here, this is a West Virginia stat that is from the National Bureau of Economic Research. 55% of all zip codes within a medium income below $25,000 are considered a food desert, that were considered in a food desert. We know that higher income homes buy and consume more health food groups, such as fiber, proteins, fruits, and vegetables, and they actually consume less processed things, such as saturated fat, sugar, sodium, cholesterol consumption. We see that across the board. We see that there is a higher income, or there's an income correlation between grams of fiber that people are ingesting, as well as a reduction in grams of sugar that people are ingesting based on an income. And so what I always tell people is if people are worried about how they're going to make so much money, like spread across a month, a week, or whatever it may be, they're looking at those things that are going to get them lasting longer. A pint of strawberries is $6. Whenever I could buy 4 boxes of noodles for $6, I'm going to look at longevity here and not nutrition value. We also see that socioeconomic status does account for variance in healthy eating choices. So people are actually, we always hear in nutrition types of education that eating the rainbow and things like that. We do see that 90% of variance in healthy eating does correlate with socioeconomic status. So when not only are people not able to eat healthy, health-dense foods, but they're also not able to eat a variety of foods, which we know impacts health. And then, of course, education does account for 20% of variance in healthy eating choices. I don't feel like I knew how to eat until I went to college and took a nutrition course. And the professor at the beginning said, this course will change your life. And I hated to admit at the end that he was right. And I have a lot of privileges in a variety of ways where I should have known how to eat, but I simply didn't until I was educated on the topic. Okay, so also exercise opportunities. I know that there were some gyms that accepted insurances. I think that's becoming fewer and fewer. My coordinator and I from our COAT group, we were looking into that for some patients, and we're not able to find easily exercise options for our patients. Or easily accessible exercise options for our patients. So telling people to get out and walk when they live out a very windy back road, they have limited transportation, again, not realistic. So asking people what they have access to, if they have access to internet, are they able to look at videos? What types of things do they like to do? What honors their process? Empowering our patients with things that already are a part of their value set and not judging and shaming them around things that we think that they should be having access to. And I think one more reiteration of this slide that I would just like to say is that public and health and social service infrastructure in West Virginia, in order for us to move forward from being the top 3, 5, whatever it may be of the worst when it comes to chronic disease and things such as that, we must address the social and structural barriers in order to have a meaningful impact. And again, that's not things that we can just do right in our office or in the rooms where we treat people. This will have to come at a higher more macro type of intervention. I will keep us moving along so we can save some time. So someone mentioned a holistic approach earlier. I really appreciate that because that's exactly how we can begin to manage these types of things with our patients. Intervention should be holistic, integrating chronic disease management, mental health support, and social services. When we're meeting with patients, whether it be on a BMed type of intervention, primary care, case management, et cetera, even if you're just talking to your patients about, I hear that you've been really struggling with anxiety lately, and you mentioned you haven't been getting much sleep. How's your sleep going? Have you been able to put your phone down a little earlier? Oh, you tried that. That's great. It doesn't have to be these huge aha moments. It can, again, be really simple types of healthy habit building for our patients. And that means that they also hear that you care and you're wondering about their sleep hygiene. Patients typically respond really well to that. And then, of course, I talk about substance use disorder, harm reduction approaches, meeting patients where they are, motivational interviewing, talking to patients. I hear you've got all this going on in your life and you're using still, but you showed up to your appointment today, and that tells me that you're still wanting to take away something from this. And that honors what they're capable of doing, and also that you see that this is a process for them and you're honoring that for them. And shouting people out can be really helpful when you're identifying what they are doing right and not, just what they're struggling with. Okay. So adverse childhood experiences, we know that these have a huge impact. And what these are, they're defined by the Centers for Disease Control and Prevention as potentially traumatic events that occur in childhood from the ages 0 to 17 years old. We consider them a major public health problem. They disproportionately impact marginalized communities, including low-income populations and communities of color. Subsequently, addressing ACEs is extremely important for an equity-driven type of approach. So what we define as what ACEs are physical, emotional, and sexual abuse, physical neglect, emotional neglect, or anything, or these household dysfunctions, such as having a caregiver or parent with mental illness, incarceration. This says mother witnessing abuse towards a mother. I think some people also consider intimate partner violence or witnessing that, substance use, and divorce. And so what we see when the ACE scores are a 4 plus, in the studies that I have here, we see some behavior implications such as lack of physical activity, smoking, alcoholism, and substance use, as well as missed work. But we know that physical and mental health complications, such as the ones listed here, are also correlated with a 4 plus ACE score. Okay, so really just some major takeaways that I would like to emphasize one last time before we get to questions or any discussion. Barriers to treatment exist on levels that are entirely out of our patient's control. Of course, we've all met patients probably time and time again whose motivation is just low. I also would challenge that in thinking, why is their motivation low? I don't know about y'all, if you've ever navigated a healthcare appointment at a big system such as WVU or CAMC, that can be really overwhelming. let alone like getting in there, getting logged on to telehealth. I work on the fifth floor in our Canal City office, and I always like really do a lot of hand holding getting my patients into the first appointment because that's so much to deal with, parking, getting there, etc. Ongoing legislation and decreases in government-funded programs will continue to negatively impact social determinants of health and our patients' quality of lives. Advocating, again, outside of our work and patients' rooms will hopefully positively impact that, but that's a big looming issue. I cannot emphasize this enough. Relying on interdisciplinary teams are superb due to enriching quality of care with a holistic approach. We alone cannot do this. We can't by ourselves. We cannot take on all of our patients' problems on our own. It's simply not in our capability to cure transportation to health appointments, let alone major depressive disorder. We're not super people. But our team members, if we come at it with a team approach, I found it to be a lot easier to manage and a lot less frustrating whenever I know I have teammates I can rely upon. Informed approaches, of course, we know trauma. We hear a lot about trauma-informed approaches, but determinants of health-informed approaches and utmost positive regard can really go a long way. People are doing the best they can with what they have, and the more that we consider these types of determinants, I believe the better types of treatment that we as providers can have or can provide for our people. Okay. These are my references.